of the many areas related to diabetes care, perhaps none is contested so greatly in the public domain as diet. And I've got with me Abd Tahrani. Abd, you're a clinician, NIHR clinician scientist, which, for those of you who don't know, is a scientist that is very much about the translation of research into clinical practice. And you're also a consultant endocrinologist. So diet wars rage. Where are we now?
Right, thank you for the invite. I think diet and lifestyle intervention are very important aspects of the management of patients with diabetes as well as patients with obesity. In fact, it's an essential part of the management of many obesity-related conditions, including cardiovascular disease and high blood pressure and many more. And there's always been a big debate about which diet is the better diet, and there's obviously a lot of industry interest in that, there is a lot of public interest of that, there is a lot of providers, and each one try to prove that their way is the right way. And I'm sure there are hundreds of books probably written already about which diet is the best and how to lose 20 stones in 3 days and something like that. And there's always a big interest in this. And part of that interest is actually because we, despite all the improvement in science and understanding about obesity, we still do not have a very effective treatment that can be applied on a population level. Although obviously we have bariatric surgery, which is very effective but not easily accessible for many patients. And because of that, there is a lot of potential diets with very little poor evidence of efficacy behind them. But one of the most important aspects was, would you like a high-fat diet? Is it better to have high-fat diet, low-carb diet, high-protein diet? Which diet is the best?
5-2 diets.
5-2 diets, yes, 5-2, 2-5, all potential possibilities. And the reality is that we still have no clear-cut evidence from randomized control trial that one diet will work better than the other for everybody. I think some diets will work better for certain people than others, but we still haven't gone in the science to that level where we can actually personalize treatment. In other words, when I see a patient who have excess weight or diabetes, I do not yet have the tools to say, I think the best diet for your metabolism is X. We still haven't gone that far, and that's partly why we still don't know what's the best diet. Nonetheless, we clearly can see some diets work better than others in some people, and whatever works well for you is the right diet for you. But from clinical efficacy, from clinical trial program, there's really no superiority of one diet over the other. What's important is to have a healthier lifestyle, regardless of the exact components of the diet. That is up till now, till we know more from a lot of evidence, a lot of research that is ongoing.
And what about what's going on at EASD this year in the obesity space? Is there anything that particularly interests you?
So I think, interestingly, in this year EASD, there are multiple trials which are related to weight, including we will know more about the Camellia trial and the cardiovascular outcome with one of the weight loss agents. However, I think probably the main focus for me and the main highlight will be on the last day when they announced the guidelines, about the joint guidelines between the EASD and ADA about diabetes management, where probably, and I'm just predicting here, probably we will see that cardiovascular management of patients with type 2 diabetes will occupy the heart of management of people with type 2 diabetes. And to manage cardiovascular disease, that means you have to manage the weight. So I think we are going to see a shift for weight management to be in the center of actually the management of patients with type 2 diabetes, which is something many people like me have been saying, to many experts as well have been saying for a long time. If you want to treat type 2 diabetes, you will need to treat obesity. This is the hardcore issue. That obviously, that doesn't mean everybody with type 2 diabetes have obesity. We know the majority do, but 10% may not. But for the majority of patients with type 2 diabetes, unless we address the obesity, we will not be able to treat type 2 diabetes. And that's why there's been a lot of attention, like the DIRECT trial, which used the very low calorie diet in people with type 2 diabetes. That's why there is a lot of interest in bariatric surgery in type 2 diabetes. They do treat the diabetes, but they also treat the obesity. And unless you target obesity, it's difficult to make great achievements with type 2 diabetes treatments.
So tell me, is it chicken or egg? So which comes first? Is it the weight gain and then the diabetes, or is it the diabetes and then the weight gain?
Okay, so there's a raging debate about this issue. Most people believe that the weight comes first, and then because of the excess weight, you start developing, accumulating fat in the wrong areas in the body, such as the liver, and that results in excess insulin resistance and then type 2 diabetes. However, there is also some good evidence to suggest that actually it starts with the body secreting too much insulin, and then that leads to obesity and type 2 diabetes. And I think there is good scientific evidence behind both theories, and that's also highlight to us that type 2 diabetes may not be the same disease in everybody. The mechanisms might be different between individuals, which also means that the treatment approaches should be different between individuals. And we aim one day, and we have the dream of being able to deliver personalized treatment where we can tell each patient, I think this is the best treatment for you, but not this treatment based on certain parameters. We are not there yet, but we are getting there. So with taking that into account, we need to think about how does that change my patient care at the moment. Will I be able, so when I see a patient in front of me who have both type 2 diabetes and obesity, am I in a position to figure out which one was the chicken and the egg? Science doesn't help me yet at that stage. So for us, it's about treating them and see what the effect is. So there is a bit of try and error here. But for the vast majority of people, and it seems definitely convincingly from the clinical trials and the science, that both feed into each other. And regardless of what's the underlying cause, treating obesity seems to have important impacts on diabetes-related outcomes, whether it is just glycemic control or, more importantly, obviously, cardiovascular disease, because that's what kills people with diabetes, not just blood sugar. What kills them is actually cardiovascular disease. And that's what have a huge impact on the morbidity of the disease. And weight loss seems to have major impact, not only on glycemic control, not only on blood pressure, not only on cholesterol levels, it has impact on cardiovascular disease and diabetes-related complications.
Finally, I can't let you go because you are an endocrinologist, and the thought that fat is an endocrine organ, I mean, that's really so recent. How has that changed people's thoughts about fat and diabetes?
Absolutely. So endocrinologists deal with the glands and the famous glands in the body, like the thyroid and the adrenal and the pituitary. Pituitary in particular secrete many hormones, which is the master gland and control everything else. And then came this fat tissue, which secretes far more hormones than actually the pituitary itself. And indeed, fat is the most active endocrine organ in the body. And that told us that on one hand, it actually explained to us the relationships between obesity and type 2 diabetes, because, okay, you get bigger, you get diabetes, but actually how does that happen? And by understanding these signals that move between the gut, the fat tissue, the liver, and the pancreas, and the hypothalamus, understanding all the signaling system, obviously improved our ability to treat patients. I mean, a lot of these new agents are actually based on this improvement of understanding, and a lot of the new agents to come will be actually based on this improvement in understanding of the fat tissue as an endocrine organ that receives signals and sends signals out that affects people, calorie intake, energy expenditure, insulin secretion, and many, many more. So it certainly transformed the scene in terms of diabetes treatment.
Well, there you are. It's all about hormones. Everything in diabetes is about hormones and not just insulin. That was terrific. Thank you so much.
Thank you very much.
There's much more on obesity in many of the e-posters on EASD.org.